Under normal conditions, the VQ relationship is 0.8. Where we're looking at the alveolar ventilation divided by the cardiac output, the V sub A divided by the Q sub T. And it's basically, yeah, that's kind of what the scenario looks like. Overall alveolar minute ventilation. There's really 5 different relationships that can exist, although the last one is one that clinically you never see, but there's obviously the normal relationship. There's a situation where you have a high VQ, something greater than 1.0. We're going to consider, by the way, the normal to be anywhere between 0.8 and 1.0. In the ideal world, it should be 1, right? For every milliliter of oxygen that enters the alveolus, there's 1 milliliter of blood flow going by. Perfect match. Reality is you don't quite get that. So something a little bit less than that. When I'm greater than 1.0, I'm going to call this a physiological dead space. With shunts, you end up having a reduction. So it's less than that's greater than that. That's less than 0.8. And a silent unit would be an example where you have no blood flow, no alveolar ventilation. I guess death would be an example of that. But in theory, at any given moment, you might have one of those 5 present in some alveolus somewhere within your lungs. This is out of your text and shows that the reduction, that as you go from, this is drawn goofy, but as you go from the bottom of the lung to the top, so as you go up the lung, blood flow goes down. In other words, blood flow is greatest in the bases. I would have drawn that differently, but then again, I didn't write the book. Ventilation has the same exact effect. The difference is they don't do it at the same rate. So blood flow is much more pronounced of a difference between the bases and the apices than the ventilation is, which yields the fact that we have a variable VA to Q ratio, variable VQ ratio as you go from the bottom of the lung to the top. Roughly 20 times the blood flow that there is the ventilation. This is again, I think this is actually out of Beachy way back when, but just showing that there are areas in the apices where you have a high VQ ratio, areas in the base where you have a lower VQ ratio. Remember, ventilation perfusion, if I increase perfusion more than I increase ventilation, my VQ relationship goes down. If I increase ventilation more than I increase perfusion, I end up having a VQ ratio that gets larger. Okay? Stop me if I'm not making sense. We're supposed to really answer. Okay, this is out of Beachy also. Was there a question there? Let me, maybe a little drawing will work out better. If this is what I'm talking about, and we said the normal is somewhere between 0.8 and 1.0, if I increase ventilation more than I increase perfusion, then my VQ ratio is going to get bigger, right? Something greater than 1. If I increase perfusion more than I increase ventilation, my VQ ratio is going to get smaller. And I'll talk more about these individually as we go along. But what this is out of Beachy again. What this is showing is that in the apices, because I have more ventilation than I do perfusion, I end up with an alveolar PaO2 that's a little bit higher than normal, and an alveolar carbon dioxide that's a little bit lower than normal. Higher ventilation, lower PaCO2. Okay? In the bases, I end up having perfusion exceeding ventilation, and when we start having a fall in VQ relationship, so I end up having less CO2 being removed, therefore the CO2 is a little bit higher, and less oxygen getting into the alveolus, because ventilation's not as high as CO2, not as high as perfusion. I end up having more oxygen being pulled away because there's more perfusion to that given alveolus. The net effect when these two mix is that I end up with my normal blood gas. But regionally within the lung, because there's different VQ relationships, there's different amounts of oxygen and carbon dioxide being exchanged. Did that last statement make sense? Okay. That's it. That's the crux of it. As you look across the lung, overall we have a VQ relationship of somewhere between 0.8 and 1 normal blood gases. But different parts within the lung, apices versus bases, you end up having a little bit of a variance from that. In other words, every alveolus is not perfectly ventilated and perfused at exactly the same moment. We're going to distinguish, I have, check the colors again here. I have 3 examples of dead space, 3 examples of shunt. This is my ideal unit. The dead spaces are all greater than 1 as a VQ relationship. And we're going to distinguish between an absolute dead space and a relative dead space. Absolute means there is 0 perfusion. It's absolute. Okay. Your trachea is an example of absolute dead space. It's anatomic dead space. Okay. Relative means there's some perfusion there, but the relationship between the perfusion and the ventilation is such that the ventilation-perfusion ratio is greater than 1. Some perfusion. A shunt can also be broken into a relative and an absolute. An absolute shunt means there's no ventilation present, a totally collapsed alveoli, a totally blocked off airway that's still being perfused. Where a relative shunt means, as the name implies, the degree to which the shunt is present is the degree to which how many alveoli aren't being ventilated. We said that absolute shunts are totally refractory, where a relative shunt, it's refractory, but it's related to how many units you have that are involved. If I only have a small amount that are present, then it's a very small amount of impact that oxygen would have a bigger impact on improving the PaO2. As that shunt fraction gets bigger and bigger, then it's going to be more of an impact, and the oxygen therapy is going to be less and less effective. And then a silent unit, we just kind of, yeah, he's there. Not much we can do about him. So let's talk about that first one, where I end up having ventilation exceeding perfusion. In essence, what you have then is a wasted ventilation. You have ventilation that is where you're expending energy more than what you need to, okay? Because you're not doing the basic function of the lung to exchange gases. Now, obviously, in order for external respiration to occur, you have to have tidal volume exceeding anatomic dead space, and that's why that rapid, shallow breathing pattern you see in somebody who's in respiratory distress is ineffective. Because then you start getting to the point where tidal volume is barely exceeding dead space, well, that's not going to be an effective ventilation. The exception to this, obviously, is high-frequency ventilation, where despite the fact that we end up having rates in the 300-400 range, you still have adequate gas exchange. Totally different process that goes on there. That's basically what we're saying. Different types of dead space, anatomic dead space. How do I determine the anatomic dead space? Okay, 1 milliliter per pound ideal body weight. I think we covered that a while back, right? Module B, 1050? Yeah. In the summer. Alveolar dead space, those areas of the lung where you have ventilation but no perfusion. And then you have mechanical dead space, stuff that we add to the ventilatory circuitry between the patient Y and the endotracheal tube. The first two, anatomic and alveolar, we call physiological dead space. Under normal conditions, mechanical ventilation or mechanical dead space doesn't exist, so the total dead space be equal to physiological dead space, but this is what we're going to end up measuring on a mechanically ventilated patient. Now, this dead space can occur either because ventilation went up or perfusion went down. So in the first case here, I had an increase in ventilation, but no change in perfusion. So my alveolar ventilation went from 5, or from, let's say 4 to 6, while my perfusion stayed the same. VQ goes up. You'll see this when you have large tidal volumes. You'll also see it when you have high PEEP levels. And that really is less having to do with ventilation as it is impeding perfusion, as in the second example. Here I end up having my alveolar ventilation not changing, but my perfusion went down. Again, same net effect, VQ greater than 1. But the problem here is not so much the ventilation as it is the perfusion. So if somebody becomes hypotensive, I actually create more dead space units. Okay. Under normal conditions, that alveolar ventilation, 4 to 5 liters, creates a CO2 of 40. If you were to double the alveolar minute ventilation, the PA CO2 would drop by about 30, or drop to about 30, should say. If you quadruple alveolar minute ventilation, going from 5 to 20, you reduce the PCO2 in half, from 40 down to 20. This is called the 20-20 rule. Anytime you see someone who has a minute ventilation that is elevated and their PCO2 is normal, you have an increase in dead space ventilation. Let me say that again, because that might be a kind of a question that a rat bastard would put on an exam. I have alveolar minute ventilation measured at 20. What should my PaCO2 be? Low, yeah, something less than certainly 30, but look, it's exactly normal. This isn't something I should be comfortable with. My PCO2 of 40 is actually an abnormality, because with an elevated alveolar minute ventilation, I should have a reduced alveolar or arterial PaCO2. If you don't, then you got a big dead space present. Some of the things we can do to treat, this is one of the reasons we tracheotomize patients. As you do a trach, you end up reducing their anatomic dead space by some amount. If I decrease the anatomic dead space, therefore the physiological dead space, I'm going to increase the alveolar minute ventilation, because you know that as I make this value smaller, I make this value bigger. This is what we talked about mechanical. Again, anything between the patient, airway, and the ventilator circuitry, the Y. Calculation of it. You know how I love calculations. In this case, what I end up having is this is a volume, by the way. I'm measuring how many milliliters of dead space I have. The arterial carbon dioxide minus the mixed expired carbon dioxide divided by the arterial. Pico, pico, pico. Does vaguely remember? Coming back to the fog. Multiply this by my tidal volume, and I have a volume in milliliters, typically, of how much dead space volume is present. If I were to just take this ratio, PaCO2 minus P mixed expired CO2 divided by arterial, then I have the VD/VT ratio, and this is a percentage. Normal dead space is somewhere about 0.2 to 0.4. So 20 to 40% of your tidal volume is wasted. When you start seeing values get above 60%, it's usually a sign that the patient's going to need to be ventilated because there's so much wasted ventilation present. Now, a poor man's estimate, I just said poor man, is using the end tidal to arterial difference. So if all I have to go on is an arterial sample and a end tidal CO2 monitor, as that gradient gets wider and wider and wider, that's indicative of dead space being increasing. It's only an estimate. How do I measure this? Anybody have any idea? Capnography is only going to give you end tidal. Volumetric capnography will, and we'll talk about that later on in the course. That's not your daddy's capnographer. It's actually a very sophisticated one. The way they do this is they collect all the exhaled gas into a Douglas bag, which is basically like a big balloon. They sample it, mix it up, draw off a sample, and run it through a blood gas analyzer. We always think blood gas analyzer, well, I can't run gas through there. Yeah, you can. You expose gas to that CO2 sensor, that Severing-House sensor, it'll actually give you a partial pressure. So that's how we get this mix expired. So clinically, do you think this is done much in the ICU? No. But in theory, this is how these values are derived. So I would have a good handle on those two formulas. They're really the same formula. One gives us a volume, one gives us a percentage. And again, that's total dead space, and when we're mechanically ventilating, because it's including any mechanical dead space present. So we talked about reducing physiological dead space. We can do it by not having excessive tidal volumes. When I say decreased tidal volume, if this is my alveolus, and my alveolus is overdistended, can we all agree that this portion in the center may not be able to adequately diffuse across, just because there's a greater distance to travel, and that transit time may not be sufficient enough to accommodate it? Same thing happens when you overdistend. Remember, we're talking about a cluster of grapes that are surrounded by a mesh of capillaries. As I overdistend them, I actually compress the vessels that are adjacent to the next alveoli. Okay, so as this overdistends, this capillary actually becomes narrower. So I reduce blood flow. Well, that's a reason why you end up with high levels of PEEP, having a reduction in perfusion in the process through the lung, and therefore you have an increase in dead space. I can also do things to make sure that my blood flow is not impaired, and that'd be things like inotropic agents, or perhaps if they're have a low blood pressure secondary to low circulating volume, giving volume or of blood. And the nasty one is the pulmonary embolus, that if large enough can cause problems. Trach them. Get rid of that extra dead space there. This is one of the on-call cases that Malley presents. 72-year-old woman undergoes surgery for a leg fracture following a fall. 3 days later, she's in acute onset of severe dyspnea, hemoptysis, and chest pain. There's the blood gases. And we see she has a respiratory rate of 30 and a minute ventilation of 18 liters per minute. Red flag. Okay. If I have an increased alveolar minute ventilation and a normal CO2, I got to think that we have some dead space issues. What's causing the dead space issues? Clotted by what? Not blood. You're right that it's an embolism.
From the bone.
From the
got a name for it, I can't remember.
Fat emboli. When you have a long bone fracture, you have an increase in fat that gets dumped into the system, and it ends up being just like a blood clot, in that it doesn't allow blood flow through there and increase in dead space. All right, let me just diverge a little bit here and talk about pulmonary embolism and the presence of hypoxemia. If you think about it, normal alveolar gas exchange is what we have on top, right? And I end up having basically an alveolar PaO2 of about 105 and an alveolar carbon dioxide of about 40. Is that a fair estimate? Nod your heads and say yes. Very good. With a pulmonary embolism, what you end up having is basically an alveolar PaO2 that's higher than what you would expect to see, because there's no carbon dioxide there. There's no CO2 being brought back. So when they mix together, you end up having basically an alveolar PaO2 of 125 and an alveolar CO2 of 20, okay, overall. So why do patients who have a pulmonary embolus have hypoxemia? In theory, it should not be there. In theory, the alveolar PaO2 is elevated. Well, it has to do with what happens as a result of the pulmonary embolus, not the embolus itself. Because dead space is not a cause directly of hypoxemia. If we go back to our causes, dead space was not listed as one. When an embolism occurs, a couple of things happen. When blood flow can't go through the area where the clot is, or the obstruction is, it's got to go somewhere else. I have to therefore have an increase in perfusion to other areas that are being ventilated. But in that case, you're going to have perfusion exceeding ventilation, which we call a shunt-like effect, which is going to drop your PaO2. At the same time, when that embolus forms, the localized tissues release all kind of chemical mediators to try and fight the inflammatory process going on. Those things that are released are things like histamine and cytokines. They get circulated around to other areas within the lung, and you end up with some localized bronchoconstriction, which reduces ventilation, which leads to a shunt-like effect. So yes, patients with pulmonary embolism do become hypoxemic, but it's all secondary to the embolism. It's not actually because I created dead space. Do you see the distinction there? In very bad cases, yes. But usually because of the hypoxemia, the patient hyperventilates. or attempts to hyperventilate to normalize the CO2 and the pH. Okay. Let's talk about the more common one we encounter in the ICU, and that's a shunt. Shunt is defined as any time you have blood going from the right side of the heart to the left side of the heart, and gas exchange does not occur. A true shunt would be where there's no ventilation. These would be examples of our anatomic shunts, our Thebesian veins, our bronchial veins, and our pleural veins. That's all venous blood, which dumps directly back into the arterial system without bypassing the lungs. It also would be when, as a relative, when perfusion exceeds ventilation. Okay. So I get venous blood basically going by an alveolus that's not inflated, and in that case you end up having blood flow, that venous blood going back into the arterial system. Again, we talked about the anatomic shunting, small amount, less than 5%. Can also have anatomic shunting secondary to a lot of your cardiac anomalies, where you end up having a right to left shunt, not a left to right shunt. No good God in heaven. Okay. And we talk about a capillary where there's no alveolar ventilation present. We always have some amount of ventilation, or typically we do. But when you get situations like these on the bottom here, I can end up having an alveoli that's not adequately being ventilated. Perfusion exceeds ventilation. And I end up with a shunt-like effect happening. Okay. Clinically, we see these all the time in the ICU. This is just kind of reiterating what I just said. Perfusions exceeding ventilation, and you end up having a reduction in the oxygenation as a net effect. So I would feel comfortable giving you an alveolar minute ventilation and a cardiac output, and you telling me what kind of condition exists, as well as doing the math. That's pretty much a no-brainer. If I have 2 liters of ventilation and 5 liters of perfusion, 2 divided by 5 is 0.4. I don't need a calculator to do that one. Okay, maybe I do. So total amount of shunting present we can express as this QS divided by QT. And we use the classic shunt equation to derive this. And we know when we get about 15% shunt, we get a significant reduction in oxygenation. Carbon dioxide is less of a problem, even though I don't have as many alveoli participating in gas exchange. Given the fact that carbon dioxide is 20 times more diffusible, it's not as much of an issue. One of my favorites. Uh-huh. Potentially. I would feel comfortable doing that. Hardest part is just takes a little bit of time to calculate. We know that in this case, this end capillary oxygen content, same formula. I can really ignore this, saying it's 100% saturated. This end capillary is this beautifully wonderful situation where every bit of oxygen in the alveolus gets across. So that's why we have the alveolar partial pressure times 0.003. The dissolved component is what's ever in the alveolus. If you really want to have fun, go online and go to Google and type in derivation of classic shunt equation. Actually, no? Okay. Pam says no. It's actually pretty cool. This is how it's derived. We know that some of the blood flow is going by an alveolus. Some of the blood flow is shunted around and not coming in contact with gas exchange. We want to quantify how much of each there is. There is something called the clinical shunt equation. It has a lot of variability. I will never expect you to know it. Okay? But just for completeness, I have to say it. There you go. Other things we can use as a surrogate without measuring the actual amount of shunt. What fun is that, I ask? One is the AA gradient, one is the AA ratio, and one is the PF ratio. You've seen each of them used clinically, I'm sure, at some point along the line, or at least discussed in the ICU. Because all three of them are good indexes of giving me an idea of how much shunt I end up having. We know that they all cause some degree of hypoxemia. True shunts are worse than relative shunts. Relative shunts depend upon how much shunt you have. Bigger the shunt fraction, more effect you're going to end up having. Treatment for a shunt is to re-recruit that collapsed alveoli. We can do that simply just by the addition of positive expiratory pressure. We can use alternative methods of ventilating somebody, like airway pressure release ventilation, which you may or may not have encountered up to this point yet. We can do things like recruitment maneuvers, put them on 40 a peep for 40 seconds. That'll pop them open. Okay. May have a little problem with hypotension, but it'll pop them open, no doubt. And doing that wonderful thing called proning, especially when you have a situation where the left lower lobe seems to be where the consolidation is at. Putting them prone will pull the heart down and will not have, because a lot of times just the size of the heart itself is helping to collapse the left lower lobe. They're all examples of how we can re-expand collapsed alveoli. There is no way that turning up the FiO2 is going to do anything. You can put them on 140% and it ain't going to do anything. Oh, okay, there's no such thing as 140%, but you get the gist of it. Okay. Silent units are silent. No perfusion, no ventilation. They don't really affect external respiration because nothing's going there. I mean, they're just basically we can ignore them. So dead space, some examples of what might cause dead space. Shunts, we talked about the different causes of shunts that you end up having. Okay? This is zone 1 is the area, and again, under normal conditions, this is almost non-existent. It's when pathology happens that we start shifting blood flow from zone 2 or 3 to zone 1. Zone 2 is one where you end up having arterial pressure exceeding alveolar, but alveolar exceeds venous. Now, if you think about it, if I have a tube, and that tube is inside of a box, what causes blood flow to move through that tube? Pressure difference, thank you. Something called the arterial to venous pressure difference is going to push that blood flow through. Pulmonary artery pressure exceeds pulmonary venous pressure, therefore blood flows through the capillary. This, however, is my alveolar pressure. If alveolar pressure becomes high enough that the extraluminal pressure exceeds the intraluminal pressure, in other words, that pressure across that tube becomes high enough, it's just like the effect that happens in the lungs as far as the dynamic compression of the airway that you have during a forced exhalation. That's why you get the scooping out of the flow volume loop. Because the pressure outside the airway is greater than the pressure inside, it collapses. Equal pressure point. Same thing can happen here. And you end up with this situation where I have a narrowing of the vessel to the point that it can actually collapse. So what dictates then blood flow through is not the difference between arterial pressure and venous pressure. It's the difference between arterial pressure and alveolar pressure. This is called a Starling resistor, for those of you who care, also known as a waterfall effect. It's in that variable zone 2 level. Zone 3, arterial pressure exceeds venous pressure, which exceeds alveolar pressure, no impedance to perfusion. In fact, perfusion flows just fine in that area. So blood flow goes up as you go down the lung from apices to bases. At the top, an example would be is a dead space, and at the bottom you have not quite a shunt, but a shunt-like effect, because ventilation exceeds perfusion. Excuse me, say that again. Perfusion exceeds ventilation. There's more perfusion than there is related ventilation. Normal VQ we said was between 0.8 and 1. True would be a 0. So true dead space is no ventilation. Excuse me, no perfusion. True shunt would be no ventilation. Dead space can occur either because perfusion is normal but ventilation is increased, or ventilation is normal and perfusion is decreased. Something that's going to make that ratio bigger than 1. We know how to calculate both the dead space volume, the top formula, and the dead space ratio in the bottom, second formula. If I have a high alveolar minute ventilation but a normal PCO2, that's not normal. There's dead space present. And we know about the different types of shunts, your anatomic shunts, the existence of a true or relative shunt. This shunt will always have an VQ less than 0.8. And really, you can't treat a shunt with anything other than re-recruitment. Alyssa.
Are we doing a fusion?
Next time.